Good afternoon, everyone. Today I will be talking about two cases of U-turns and uveitis. There's a popular quote which says that when one door closes, another opens. But we usually look at the closed doors for so long that we do not realize the door which has already opened for us. This was a 17-year-old boy who had come with complaints of decreased vision in both his eyes for 5 months. The vision in his right eye was 6/36 and in the left eye it was 6/9. His anterior segment examination in both his eyes was normal. The posterior segment examination of both eyes, it showed a pigmented chorioretinal scars in both his eyes, and there was a geographic helicoid pattern which was seen at the posterior pole. The OCT of both the eyes, it showed macular edema. The blood investigations of the patient was normal and the Mantoux test was positive. Because we saw the pigmented chorioretinal scars along the vessels and the Mantoux test was positive, we went ahead with a CT chest which showed healed tuberculosis. Therefore, now our differential diagnosis for this patient was ocular tuberculosis. And we started the patient on ATT along with oral steroids. And as he had macular edema, we gave both eyes posterior subtenone, triamcinolone acetonide in both the eyes. Now, after 3 months, in spite of receiving 2 injections of PST, the edema was still persisting. And we were now in a dilemma, like after completing 3 months of ATT and receiving 2 doses of PST, the macular edema was still persisting. So is it really ocular TB or is it something else? So we re-looked into the OCT again, and when we saw the OCT, we saw that there was a thickening of the outer retinal layers which was seen, and there was an elongation of the photoreceptors. Therefore, we went ahead to do an ERG for the patient, which showed a reduced scotopic and a photopic response. The electrooculogram, which showed a reduction in the light peak to the dark trough phase, and the Ardens ratio, especially in the left eye, it was reduced to 0.8. So the fundus autofluorescence, it showed hypoautofluorescence around the macula in both the eyes. So now the patient was initially diagnosed as ocular TB, but looking at the ERG, EOG and the fundus autofluorescence, it doesn't fit into the ocular tuberculosis diagnosis. So we had to revise our diagnosis into autosomal recessive bestrophenopathies. So autosomal recessive bestrophenopathies, it is a clinically recognizable phenotype. Even without a prior genetic analysis, it can be diagnosed. So bestrophenopathies is because of the BEST1 gene mutation, and this bestrophin 1 is the protein product of the BEST1 gene, and the ionic metabolism of the RPE cells and the normal ocular development are adjusted by this protein. So in autosomal recessive bestrophenopathies, the visual acuity is normal, or there can be a central visual field loss. So it's quite surprising that how can the vision be normal in spite of a significant separation of the RPE from the photoreceptors. It is because of the fluid which is there has an ionic composition similar to the interphotoreceptor matrix. That's why we see a normal visual acuity. We see hyperopia and a shallow anterior chamber because of the genetic mutations, and punctate retinal flecks are being seen at the posterior fold, and subretinal fluid is being seen at the macula, and it can extend beyond the arcades. In the OCT in autosomal recessive bestrophenopathies, it shows thickening of the outer retinal layers. You can see an elongation of the photoreceptors, and you can see serous retinal detachment, and you can see retinoschisis. So why do we see serous retinal detachment and retinoschisis? It is because there is a change in the calcium and the chloride pumps, and as a result there is an RPE pump failure and there is an accumulation of the fluid, and because of the ionic pump failure, the Muller cells also fail to function, and as a result we see retinoschisis. The ERG, it shows, is usually suboptimal, and the light peak to dark trough ratio is severely reduced. The fundus autofluorescence, it shows hyperautofluorescence of the subretinal deposits, and usually if it elongates, it is called as a track sign, and it indicates chronicity of the disease. So this autosomal recessive bestrophenopathies is usually misdiagnosed as CSR or chorioretinitis. There's a report by Boone et al. Where a patient was being treated as chorioretinitis, but later on she was diagnosed as autosomal recessive bestrophenopathies. So this is a similar patient we had who had come from Calcutta, and she had come all the way to Madurai, and she was diagnosed as serpiginous like choroiditis, and she was treated with ATT for 9 months, and we can see the typical pattern fundus autofluorescence and the OCT also, but she was lost for follow-up for ERG and EOG. So the key takeaway in this case is that since this is a recognizable phenotype without prior genetic analysis, early detection helps avoiding unnecessary treatment. Multimodal imaging is useful, especially in ARB cases, because you can detect the abnormal areas, and genetic analysis will give you a definite diagnosis. So coming to the second case, this was an 11-year-old boy who came with defective vision in both eyes and with pain and redness since 1 week. His vision in his right eye was 6/36 and left eye was finger counting close to face. He had anterior uveitis in both his eyes. This was his fundus, which showed disc edema and serous RDs at the posterior pole. The B scan, it showed a serous RD and the thickening of the choroid. And the OCT, it showed large serous RDs in both his eyes. The patient was allergic to the fluorescein dye, so we couldn't do an FFA for the patient. So our diagnosis for the patient was both eye pan uveitis, Vogt-Koyanagi-Harada disease, and we started the patients on oral steroids and oral methotrexate 20 mg per week. But over here in this patient, we could not reduce the oral steroids to less than 10 milligrams. Every time we reduced it to less than 10 milligrams, there was a recurrence of inflammation. So we now added another immunosuppressive drug, that is mycophenolate 250 mg BD. The inflammation resolved in both eyes, and the vision was 6/6 in both his eyes. 8 months later, we saw that there was a recurrence of inflammation in spite of being on 2 immunosuppressive drugs and an oral steroid. So this time we added a newer biological patient for the patient, that is adalimumab. The inflammation subsided and the vision was 6/6. 3 years later, we saw that the iris had got small granulomas inferiorly. And the fundus examination of the right eye, it showed a small choroidal granuloma just above the disc. So now we were in a dilemma because these are features which we do not usually see in Vogt-Koyanagi-Harada disease. So we suspected the patient to have drug-induced sarcoidosis, and there is a lot of literature which shows that adalimumab, it causes sarcoidosis, and this is because of the increased release of the cytokines. So we did a CT chest, which was normal for the patient, and suspecting him to have adalimumab-induced sarcoidosis, adalimumab was stopped, and we asked the patient to continue oral steroids with oral methotrexate. The inflammation resolved in both his eyes, and his vision was 6/6. But 8 months later, we again had a surprise. There were multiple small choroidal granulomas which were there at the posterior pole. So we thought of re-evaluating the patient once again, and we did blood investigations, which was completely normal. And the Mantox test, which was initially negative for the patient, now turned out to be positive. So now these features were more in favor of ocular tuberculosis. So we started the patient on ATT, and he completed his ATT for 6 months. And to prevent the recurrence of VKH, we added oral steroids. And at present, he has got no active inflammation in both his eyes, and his vision is 6/6. So we have the Visual 3 trial, which is one of the largest trials which checks for the safety and efficacy of adalimumab in patients with non-infectious uveitis, and it was seen that 5% of the individuals developed tuberculosis, in which 15 had got latent tuberculosis and 1 had active tuberculosis. So the key takeaway message from the second case was the risk of tuberculosis in patients on adalimumab is 8 to 12 times greater in countries with a low incidence of TB, and 24 to 40 times greater in countries with high incidence of TB. And the time from the initiation of anti-TNF therapy until development and diagnosis of tuberculosis was approximately 18 months. So when your diagnosis, treatment, and the course of the disease does not meet the desired clinical outcome, never shy away to reevaluate the patient and change the diagnosis, and never lose hope, because we always have light at the end of the tunnel. Thank you for listening.
Very nice cases, especially the second case, which presented as a VKH and turned out to be, and the patient was put on immunosuppressive agents, and because of adalimumab, the patient acquires tuberculosis. Especially the first case, the patient presented, patient had no uveitis. So we should be very thorough with to detect the inflammation. In absence of inflammation, better not to start any steroids, because the first patient had no inflammation at all. The vitreous was clear, and the symmetric involvement in both the eyes that pointed towards the dystrophy rather than a uveitis. Anything Madam would like to add?
Congratulations for the very nice case and good learning point for all of us.
Thank you.
Yes, the bestinopathy most of the time is confuses with uveitis, especially when they present with serious retinal detachment. In your case, has nice elongation of the photoreceptors and retinoschisis. In that situations, we do suspect the possibility of bestinopathy. So we had 5 such patients who mimicking uveitis. Initially, in fact, the first 2 cases was put on steroids, no response, was put on immunosuppressions, no. And then when we re-evaluated, started showing the signs of retinal schisis findings. At that time, we made the diagnosis of bestinopathy. So important thing, whenever we see a bestinopathy, this thing is shallow anterior chamber need to be evaluated and managed. In fact, one patient presented very late because of the clinical examination, we could pick it up. So it's important not only we evaluate and keep a close watch for the shallow anterior chamber and watch out for the glaucoma, do this family screening to pick up the similar cases, and it's important. Yes, bestinopathy, B1 gene, if they can afford, we can isolate it. Otherwise, clinical examination and the other electrophysiological workup help us to come to the conclusion.
Yes, ma'am.
Yes, and in the second case, when you put the adalimumab, when the patient developed a tuberculosis like picture after 18 months, did the patient had any systemic manifestations in addition to the ocular tuberculosis?
No, ma'am, he didn't have any systemic manifestations. He had just decrease in vision in both his eyes, and he had no history, symptoms suggestive of TB or any history of TB contact also, ma'am.
Very nice cases and well managed. Congratulations, and thank you once again.
Thank you, ma'am.
Second point I would like to add regarding adalimumab, as Dr. Anjana has pointed out, that sometimes the biologics we give for treatment of inflammatory diseases, but they can itself cause some other autoimmune disease. Like she has pointed out, it can cause sarcoidosis. In addition to that, it can also cause psoriasis. So one should be aware of that. These biologics, before starting, first rule out tuberculosis and inform the patient that those agents can also induce some other autoimmune disease in the body. So now let us come back to the basics of uveitis. We know that the standardized uveitic nomenclature classification number 1, which was published 2005, and now we have 2020 classification, that is SUN2. So this classification is based on the etiology. The first one, what we had, that was about the classification, anterior, how you will call uveitis as anterior uveitis, intermediate and posterior or pan. But this classification talks about the etiology. So may I request Dr. Namita to talk on the standardized uveitic nomenclature 2, what has changed?
Good afternoon, everybody. At the outset, I would like to thank the organizer of BOS for giving me an opportunity to speak. Today, I'll be talking on standardized uveitis nomenclature 2. What has changed? Uveitis is the fifth leading cause of blindness. In spite of such huge numbers, a lot of discrepancies existed regarding terminologies, definition, classification, grading. So in 2005, the attempt was made to standardize reporting of clinical data. And it was affirmed that classification of uveitis to be done based on anatomical location. This enhanced the comparability of clinical research across countries and permitted a meta-analysis. So a standardized scheme was developed for grading, for definition of each subset of uveitis, for definition of terms like inactive, inflammation, improvement, and this was a first step towards setting a standard. So as you all know, anatomical classification was based on anterior, intermediate, posterior, and pan. This was a various grading of classification done for flare and cells, and including definitions for outcome, course, and remission. The ambiguities which were there in the international Uvea study groups were also addressed. It was decided that intermediate uveitis is the term used when the vitreous has maximum inflammation, and pars planitis will be that subset of uveitis where snowbank or snowball formation is there in the absence of any systemic disease. They tried to get a retinal a consensus on the definition of retinal vasculitis, but a lot of work was needed to be done still for this. So the first international workshop produced consensus on several issues, and this was found as a framework for subsequent work on various diagnostic criteria for specific uveitis. As you all know, uveitis affecting a particular location can have distinct etiologies, clinical course, prognosis, or treatment. The Sun 2 classification was developed in 2021. It was published to give the classification criteria for 25 uveitis conditions. The objective was to establish a uniform group of patients for inclusion in research studies and to maximize the probability that all the participants were accepted as having the disease. So using these 4 phases, the criteria were developed. So there was case selection, case collection, case selection, machine learning, and the final consensus, which was later published. Around 5,766 cases were put into database, which average about 100 to 250 cases of each uveitis. This was reviewed by the study group, and when there was consensus of more than 75% for the criteria, they were only included into the final database. The final case input was around 4,046 cases. Using machine learning techniques, they established a set of criteria to define the classification criteria for the 25 common uveitis conditions. The 85% of the cases were the training set, of which 15% were used to validate the criteria. Basis for the future uveitis research. The overall accuracy was based on anatomical locations. Highest was intermediate uveitis around 99.3%, and lowest was infectious posterior uveitis on 93%. So the classification was the uveitis conditions which were used were in anterior, we had the infective group of CMV, HSV, herpes zoster, and syphilis. Systemic were JIA, TINO, spondyloarthropathies, and the localized to eye were Fuchs. Among intermediate, it was syphilis in infectious group, cirrhosis and sarcoidosis, and in the localized group, it was pars planitis. For posterior, ARN, CMV, syphilitic, and toxoplasma and tubercular were used, and for eye limited were the multiple evanescent white dot syndromes. For pan-uveitis, it was mainly syphilis and tuberculosis, and associated systemic disease pan-uveitis was Behçet's, sarcoid, and leakage. For localized, it was basically sympathetic ophthalmitis. So these 25 conditions, the classification criteria was given. These criteria performed well enough for use both in clinical and translational research, but it should be recalled that classification criteria are intended primarily for research and they differ from the diagnostic criteria. This was one of the largest such exercises in any field of medicine, let alone ophthalmology. It created a homogeneous group of most representable cases in any disease category of clinical research. So classification criteria basically emphasize your statistical specificity. Diagnostic criteria emphasize sensitivity. So a patient in your clinic may be classified clinically as having a specific type of uveitis even though they do not meet the SUN2 criteria for that uveitis subtype. To conclude, SUN2 classification has classified common uveitis condition for research purposes, so we all now are on the same page when we compare our data across the world. These are the various references. The classification criteria of each condition I have not explained because I think due to lack of time, but I think in any of the articles you should be getting the classification criteria to use for research purposes. Thank you so much.
That was a nice presentation. So now we should know that what is a diagnostic criteria and what is a classification criteria. Just to summarize that, what has changed in this SUN2 classification is definition of few uveitic entities. Now, if you isolate any virus, say herpes zoster or herpes simplex, from a case in which you are suspecting Fuchs uveitis, you can't no more call it as Fuchs uveitis. You have to label it as a viral endemic uveitis. Definition of ARN, there is a changes. If the clinical pattern is like ARN, but you isolate, say, CMV, or correlate that disease because of, say, syphilis, you no more use the term of ARN. You have to call it as because of CMV retinitis or syphilitic retinitis. But ARN term should be used only if you isolate HSV and VZV. There are many such changes in that. For example, serpiginous choroiditis. If the MAN2 is positive and quantiferon is positive, you can't call that entity as serpiginous choroiditis. So I will request you to read the 2020 published article in IGO about this SUN classification too. So let us move on the next topic. That's when and how I should refer to a uveitis specialist by Dr. Manjula.
Good afternoon. At the outset, I would like to thank BOS and Dr. Ankush for giving me this opportunity. My topic, I have divided, slightly modified into why, because we should understand the importance of reference, why, when, and how I should refer to a uveitis specialist. So first, we should understand why, because uveitis comprises of ocular inflammatory diseases, which include both infectious as well as non-infectious etiologies. Due to the complexity of its nature, it's not easily recognized, and this leads to a delay in diagnosis and associated complications. The conditions are not only some are restricted to the eye, but majority are related to systemic diseases. The causes can be idiopathic, autoimmune, infectious, or masquerade. And the conditions vary in their clinical course, treatment, and prognosis. Very few conditions have a limited course with a favorable prognosis, requiring short-term treatment. However, the majority of the cases require prolonged course with severe visual compromise requiring long-term treatment. And they also include a multidisciplinary team, including rheumatologist, internist, neurologist, infectious disease specialist, and other ophthalmology specialists. Hence, and when we looked into this study, where they studied around 430 referred cases of uveitis in a tertiary care center in Colombia, the mean time between the first ocular symptom and the uveitis specialist evaluation was 2 years. And only 4.7% of the patients were correctly graded according to SUN classification. And at the time of first consultation with the uvea specialist, only half of them arrived with an adequate infectious panel, more than half with adequate rheumatological panel, and 11.6% with aqueous humor PCR study. And 34.9% of the total patients were on inadequate topical treatment, and more than half were with inadequate systemic treatment. And the mean time for the uveitis specialist to confirm the diagnosis was 5 weeks. A diagnostic coincidence was not reached in about more than half of the cases. So this highlights the importance of early referral, and the general ophthalmologist must be aware of the standardized classification of the disease, appropriate treatment according to the classification, and early referral with adequate lab tests. Now, when should I refer? This is the second one. So coming to the most common type of uveitis is anterior uveitis. The causes can be idiopathic, inflammatory, infective, sometimes medication-induced, traumatic, or neoplastic. Non-granulomatous anterior uveitis, when you are not suspecting any viral infection or no systemic manifestations, usually the workup is not required. But if the recurrent episodes, it requires adequate workup and referral. Hypopyon anterior uveitis, even if the first time, should be referred with adequate lab tests. Granulomatous anterior uveitis, it can be a part of a pan-uveitis, or it can be caused by systemic inflammatory conditions like sarcoid or systemic infection like tuberculosis. So needs a systemic workup with early referral. Intermediate, posterior and pan-uveitis require an early referral because they are vision-threatening conditions, and it requires a multidisciplinary approach with the help of either an antimicrobial agent with infection disease controls or with the immunomodulatory drug by the rheumatologist. So now how should I refer? So whenever you see a case of uveitis, complete history taking is very important with a review of the symptoms and signs. And next, detailed ocular examination with slit lamp and fundus examination is required. With these two, you can classify the anatomical location of the uveitis. And with these three, the symptoms, signs, and the classification, you should be able to arrive at a differential diagnosis. And according to that, please order the workup. So comprehensive history is very important. Medical conditions, medications, and family history. Some of the drugs like biphosphonates, cancer immunotherapy, and vaccination can cause secondary uveitis. For example, if you see this lady, she had poliosis, vitiligo, and panuveitis. Is it VKH? But if you see the history, she gives history of metastatic melanoma, and she was treated with treatment with checkpoint inhibitors. So these medications can also cause a secondary uveitis. And when it comes to ordering the test, be careful, because ordering everything is not the best and can be detrimental sometimes. And that which manifests with a presenting sign should be ordered. Here, the patient demographics and the clinical presentation should guide for the further tests. It should go in a stepwise approach. Minimal workup, what is required is a complete blood count, ESR, CRP. Syphilis is, yes, it's a masquerade. This should be included in your lab test. And tuberculosis, because India is endemic for TB. Step 2 and step 3 is guided by your anatomical classification, the clinical findings, and the medical history. Depending on what we are dealing with, we should order the tests. Next, I'll give you an example. ANA is positive in around 31.7% of the general population. The pre-test probability is greatest when you have occlusive vasculitis. If you see this picture, recurrent attacks of acute anterior uveitis, but if you see carefully, there are iris transillumination defects. Unfortunately, the ANA is positive. The patient will be put on high topical steroids and if required, immunomodulatory drugs. But be careful, this is viral and it requires an antiviral with a low dose topical steroid. So hence, unnecessary investigations not suggested. And when you see the first time a patient, always dilate in any uveitis case, because you will be missing the most vision-threatening condition like acute retinal necrosis if we don't dilate. And when you are ordering the lab test, remember, don't forget about infection, especially syphilis and tuberculosis. And when you are dealing for the first time, you have not had your etiological diagnosis, don't inject intravitreal or periocular steroids. Last, but not the least, not everything is uveitis. This gentleman, he was a 67-year-old male. He was treated for almost 6 months for intermediate uveitis with topical and systemic steroids. No response, and then referred. If you see the OCT carefully, you see those subretinal changes. They make you think of masquerade. When I did a biopsy of the vitreous, it showed atypical lymphoid cells, and it was a case of primary vitreoretinal lymphoma. So the key points here is, before you send, thorough history and complete examination. Infectious disease should be kept in the differential. Masquerade you should think of when the treatment response is not adequate. And the lab test and etiological diagnosis is very important. Thank you.
Nice presentation. So documentation of the findings is very important to us, because when the patient you refer to us and we don't find anything, we rely on the history. So unless you document that the uveitis was granulomatous or non-granulomatous and patient is on steroid present to us and there are no KPs, so we can't make the diagnosis of non-granulomatous or granulomatous. So documentation of these findings are very important. And please do not start steroid if you are referring to us, because steroid will mask all the findings. So moving ahead from the history taking and the clinical findings, now we should uh, look at the biomarkers, imaging biomarkers in uveitis. So may I request Dr. Padmamalini to give her talk on this topic.
Very good afternoon to all of you. Coming to imaging biomarkers in uveitis, imaging can be done by studying the keratic precipitates in the anterior chamber of the eye to the photoreceptors in the retina. Pole to pole, we can examine each structures in the eye. Coming to the etiology, it could be due to infective or autoimmune or idiopathic. I'll be sharing imaging biomarkers in our practice, which has helped us to clinch the diagnosis. It's a case-based approach. Pearl 1. Here is a 21-year female presented with decreased vision in the left eye since 3 days. She gave history of fever, with visual acuity was decreased in the left eye to 624. On fundus examination, we could see the areas of retinitis, retinal hemorrhages, impending vein occlusion was seen. When we did the OCT, we could see the hyperreflectivity in the outer plexiform layer, Henle's layer and outer nuclear layer, which ultimately led to the localized disruption of these outer retinal layers. Classically, what is described as foveolitis. When we look at this foveolitis with the history of fever with retinitis, we thought of dengue as differential diagnosis, and FFA showed hypo with late hyperfluorescence, and dengue IgG antibody was positive. We treated the patient with systemic steroids. We could see the resolution of the retinitis and foveolitis in this case. The imaging biomarkers helps us to tailor make the investigations. Now, currently the epidemic of dengue is going on in Bangalore. We can expect more number of dengue-related retinopathy or foveolitis in our clinic. The next comes the case of post-fever retinitis. Whenever we have patients with fever, they present with retinitis and retinal hemorrhages, what classically described as a post-fever retinitis. It could be secondary to dengue, chikungunya, West Nile, or rickettsial infection. We have described ring-like retinitis whenever we see. This could be one of the morphological features of post-fever retinitis. Here is a 27-year male presented with blurring of vision. Headlight in the fog is classically described in toxoplasmosis, which is the commonest cause of infectious posterior uveitis across the globe. When we do a OCT, we could see the hyperreflective, this oval deposits at the vitreoretinal interface that classically seen in case of toxoplasmosis. In addition to that, we see increased hyperreflectivity in the inner and middle retinal layers with the choroidal bulge. So it's a case of retinochoroiditis. This particular morphological pattern of deposits which is present in the vitreoretinal interface also gives us a clue, probably secondary to toxoplasmosis. The patient was put on antitoxo treatment and steroids, following which we could see the resolution of the retinitis in this case. Coming to case number 4. Here is a case of a post-COVID retinopathy, start of immunological reaction, and the patient was on systemic steroids. And during the course of the disease, the patient developed yellowish lesions in the mid-periphery of the fundus. When we put the OCT, you could see the pre-retinal aggregate termed what is described as rain cloud sign. This is classically described in case of candidiasis. That gave us alarm when we investigated. This patient found to have a candidiasis. Following antifungal therapy, the patient responded well to antifungal therapy. So the next comes a case of herpes zoster. As all we know, herpes zoster commonly affects the anterior segment of the eye, the unilateral presentation with uveitis or sometimes scleritis or keratitis. Here we have noticed multiple hypo-reflective lesions in the fundus. On FFA, you could see the hypofluorescent lesion, and ICG also showed hypofluorescent lesion in this patient. OCT shows cystoid macular edema with reflective choroidal granuloma. Following treatment with antiviral and steroids, this granuloma was resolved. This is similar to what we have seen in a case of a TB or sarcoid granuloma. This herpes zoster also can present in the form of granulomas in the choroid. Next comes the pearl number 6. Here is a case of a bilateral posterior uveitis treated with steroids, did not resolve well and referred to us. You could see the media haze with hyporeflective, pigmented lesions in the posterior segment of the eye. Autofluorescence shows hypo with hyperautofluorescence, what classically described as mottled appearance. And OCT, when we passed it, we saw the this is subretinal deposits, which is already showed my previous speaker, Dr. Manjula, in a case of a primary intraocular lymphoma. This is a subretinal deposits. Whenever we see this, this could be an imaging biomarker where we have to suspect intraocular lymphoma, or they can have vertical hyperreflective lines. This could be the earlier presentation compared to the subretinal deposits. In addition to that, we have described white keratic precipitates. It's classically seen in a case of intraocular lymphoma. When we did the confocal microscopy, we saw both floral, complete and incomplete pattern, which resolved following treatment, which we have described as one additional imaging biomarker in suspected case of intraocular lymphoma if they have anterior segment spillover of inflammation. Next comes Pearl number 7. Here is a 51-year male presented with headache, photophobia. He also had history of pericarditis, history of COVID infections, treated with monoclonal antibodies in US. Patient presented with pain and discomfort, fine KPs, we could see the cells, and when we put the confocal microscopy, we saw polymegathism. In addition to that, we saw owl-like pattern of deposits in the corneal endothelium, which classically described in a case of a CMV endothelitis. This particular patient, AC-TAP for PCR, came negative for CMV virus, but in spite of the imaging biomarker, we went ahead and treated the patient with ganciclovir therapy, following which we could see the resolution of the inflammations and changing pattern and endothelium. So this is a post-treatment where you can see the reversal of endothelial changes in this patient. Pearl 8 is a case of a 58-year male presented with retinal hemorrhages and retinal infiltrate and vitreous hemorrhages. Retinal vascular sheathing was there. Carefully, when we look at it, we could see the rod spots in the retina. Whenever we see a rod spots, we need to rule out hematological abnormalities. We saw the abnormal OCT hyperreflectivity. This is a scene in a case of a chronic myeloid leukemia. The figure of 8 pattern is altered in a vessel. This is hyperreflectivity filling the lumen. FFA shows NVD, NVE, significant CNP areas, and this is sting of bead appearance on FFA. The sting of beads appearance on FFA we described as an imaging biomarker in a case of a CML on FFA. So, and also they presented in the form of multiple miliary aneurysms, could be leukemic retinopathy biomarker. So with this, I would like to conclude various imaging modalities can help not only in making the correct diagnosis and documenting and following the patients after therapy in inflammatory conditions of the eye. These are my acknowledgements. Thank you for your attention.
So this was the science, specific science based on which you can think about a uveitic entity. But what you will do when there are no specific signs, what you see is just few cells in the antechamber or very mild kind of vitritis. There are no specific lesions on the retina or fundus examination. Then we have to rely on our systemic evaluation. So here we have august presence of rheumatologists among ourselves, and Dr. Vikram Jain will guide us on how to pick up those systemic clues in our uveitis cases.
So good afternoon, everyone. Thank you for inviting me here for this talk on systemic clues not to miss in uveitis. And as a rheumatologist, we always think of ourselves as detectives who are always looking multi-system organ involvement to find our diagnosis. So obviously uveitis has varied etiology. We saw in the previous speakers discussing about that. And sometimes it can be very challenging diagnostic dilemmas. So to have a diagnosis, we would obviously, as in any other medical branch, obviously history followed by clinical examination and directed investigation so that we avoid false positive results as well as unnecessary testing is the key. So we have already seen the different anatomical etiologies for uveitis. I'll just discuss what is the most common immune-mediated diseases associated with uveitis. And for us, obviously, spondyloarthritis, sarcoidosis, Behçet's, JIA, which we as rheumatologists commonly come across as causes of uveitis. but sometimes lupus, vasculitis also can be causes of uveitis. Multiple sclerosis worked, VKH and all, usually as rheumatologists, we don't see as that often because these manifestations are usually neurological. There are other rare causes which I'll not deal into detail, but if you look at the four most common causes, I think all of us should be attuned to what to look for to diagnose these patients in patients with uveitis. So I'll just discuss what is the diagnostic criteria for Behçet. And if you look here, there are no markers or no test to say, okay, this is Behçet. And for ankylosing spondyloarthritis, we have HLA-B27, again, which is positive in 90% patients with spondyloarthritis, but patients may be negative. And the main diagnostic for us especially is basically clinical, where you're looking at arthritis, dactylitis, psoriasis, enthesitis, IBD, etc. So you have imaging, you have HLA-B27, but main features are clinical on which you basically suspect. And sarcoid, as you all know, we don't have it is basically biopsy, where you have a compatible clinical picture with biopsy and excluding other cause where you put in diagnose as sarcoid. So the most important or the most common causes, if you look at, we don't have a definitive, very strong test to definitely say that this is the disease, and we need clinical parameters of history and examination to guide us in patients with uveitis to look for these causes. So as I said, the ease of diagnosis sometimes for us is very self-evident. A patient comes with very classical findings, but most of the time the symptoms are very, very vague, very initial, just joint pains, very non-specific arthralgia, myalgias, and we may require multiple visits or observations for symptoms to evolve. So the key again is careful history taking, examination, following by investigations to supplement and not substitute our judgment. So I would just try to take you through how we as rheumatologists look at patients who come with uveitis, how we approach. So we may think as rheumatologists, for us tests is everything, ANA profile, ANCAs, ACE, but it's basically the history. And it's the history which is main, gives us 80% of the diagnosis. So we always take a very, very detailed history. It's a history, which actually gives us a diagnosis, majority patients, and only we use tests to confirm these our differentials. So age of onset, just starting from age of onset. So JIAs, obviously children, but most of our diseases, spondyloarthritis, are usually in young men. So young men coming with features of uveitis, anterior uveitis, you always think of spondyloarthritis. Sarcoid, Behçet can obviously occur in any age group, but some diseases, obviously we have a certain age onset where we can think of certain diagnosis. So again, gender, again a not very good differential, but differentiator. But men, young men coming with back pain, joint pains, uveitis, obviously our thought process is towards spondyloarthritis. And many times we get a referral saying patient with uveitis, so and so uveitis having joint pain. So again, joint pains is very vague. We always look for arthritis, definitive features like, so for arthritis there should be pain, there should be swelling, there should be early morning stiffness lasting for half an hour, 1 hour. So patient has these symptoms, then we are more interested now that this is a strong or a hard feature where we should further evaluate and look for underlying autoimmune disease. And how we as rheumatologists approach is this: if somebody comes with joint pain, it's not just okay, joint pain is there, we need to do these tests. So we look into whether it is sudden, is it insidious onset, whether it is a single joint, it's a multiple joint, whether there is axial disease. So patient has neck pain, back pain, inflammatory back pain, whether it is symmetric, asymmetric, whether it is what is the local pattern of joint disease, whether there is also a dactylitis, enthesitis. So if I look into and form a pattern of this arthritis, I usually majority of patients, we know that this is rheumatoid, this is ankylosing spondylitis, this is so and so. So this is how we approach. So one important concept, obviously, because we deal with spondyloarthritis so commonly, is the concept of inflammatory backache. So most of us have had backache sometimes during our lifetime, but most of it is mechanical back pain. That is, it can occur at any age group. The onset is very acute usually. It may worsen with movement and often improves with rest. Compared to an inflammatory back pain on the left side, in a younger patient, very insidious onset, it improves with exercise, does not improve with rest, very significant morning stiffness. if you have these, if you just ask these questions and patient has these features, you are more or less sure this is inflammatory back pain, this is spondyloarthritis. I don't even need to do a further imaging or testing. So majority you'll make sure that this is ankylosing spondylitis. So other features like something which is very visual, you can see that is if you can look at these toes which are swollen, the sausage-like digits, especially in the toes, or in the hand, the fingers are swollen. Some fingers are swollen, some are not. If we have this feature, this is called as dactylitis. This is a very peculiar feature of spondyloarthritis, gout, and certain features. So if you have a patient with uveitis and if you have dactylitis, then we are sure, okay, we are looking at these sort of differentials in our mind. Sarcoidosis, spondyloarthritis, gout, these are some of the common causes of dactylitis. Another important feature which we look for is enthesitis, where enthesias are the regions where the tendons, ligaments attach to the bone, and inflammation at these sites, especially say Achilles enthesitis or around the knees. So if patient has swelling around the ankle, behind the ankle, you are interested now, okay, this could be spondyloarthritis group like a psoriatic arthritis or an ankylosing spondylitis. So some peculiar features of certain disease, very visual, you can just have a look, a general examination will give you these findings. So just to give you how we approach it, so young male with a low back pain, alternating buttock pain, more after rest, improves with activity, early morning stiffness. So now we know you have a young male with inflammatory back pain and pain and swelling of the small joints of the knee joints, so which is insidious in onset with axial and peripheral, that is both the spine, that is a back pain as well as joint pains. So this is most likely going to be a spondyloarthritis group. So this is how we approach the arthritis, the pattern of arthritis, that gives us the diagnosis. I am 99.9% sure that this is ankylosing spondylitis. I just need maybe, if in doubt, maybe an X-ray or an MRI rarely. So other histories like past history of psoriasis, DVT, especially patients like Behçet, or very underrated is family history. Very often we see patients with uveitis and you ask any other member in the family has any autoimmune disease and they say my brother or my father has ankylosing spondylitis. That's enough. 99 you are very sure that this is going to be a spondyloarthritis associated uveitis, or patient may have history of, so all patients may not have the same manifestations. There can be psoriasis in family member, a family member may have spondyloarthritis, another member have inflammatory bowel disease. So this spectrum of disorders if you find in a family, you're sure with this history alone you will make a diagnosis of this is probably a spondyloarthritis associated uveitis. Now for us as rheumatologists, obviously the joints are not the only thing. To make a diagnosis we look beyond the joints. Again skin, where you may have psoriatic lesions which may be very obvious in the scalp or in the nails, but sometimes maybe they may be hidden, like it may be just below this, you just lift the hair and you can find psoriatic lesions. It can be behind the ears, it can be in the umbilical region. So these are very small, very important clues for us that this is psoriasis. Patient themselves may not be aware that they have psoriasis. And if you find that these findings, then with the uveitis, you can make the connection. Again, lupus has very, very varied manifestations. The classical malar rash, subacute lupus, discoid rash, paniculitis, very varied manifestations. Obviously, some may be very specific, some may be very non-specific. Sarcoid, because this is an important diagnostic diagnosis for us, patients may present with erythema nodosum, violaceous or fleshy skin lesions over the face, or scars having patient who has undergone a tattoo or a scar and there are scar lesions. So these suggest of a sarcoidosis. Other cutaneous manifestations, especially in Behçet, as I said, is a clinical diagnosis. So patient may have oral ulcers. So oral laphthe with the, you can see these lesions over the lips with the surrounding erythema and over the tongue and scrotal lesions. So in a Behçet, if somebody has genital ulcers, that is very, very specific for Behçet, just like a posterior uveitis or a retinal vasculitis is very suggestive of Behçet. So scrotal ulcers, pustulous lesions, erythema nodosum, oral ulcers. So these are the things which you make us think of Behçet. So small vessel vasculitis like Anca vasculitis can have varied manifestations like palpable purpura, ulcers, gangrene, subcutaneous nodules. You may have to do a thorough examination, but these are some important clues for us. VKH already has been dealt. Sometimes patient may have very gross findings like this parotid swelling which may be seen in sarcoid or Sjogren. There can be ENT manifestations like nasal polyps, crusting, septal perforation, saddle nose which may be sometimes very obvious. which may suggest of a granulomatous polyangiitis. Pulmonary manifestations like pleural effusion, lymph nodes, hyaluronopathy. Again, we need imaging for this, but may not be very obvious clinically. Alveolar hemorrhage, lung nodules, etc. So, what I'm trying to put across is you need to see all over. You need to start from head to toe, looking at the eye, looking at the skin, the ENT, the parotids, the lungs, and there can be other manifestations like urethritis, cervicitis in reactive arthritis. Generalized lymphadenopathy may be seen in lupus, TB, sarcoid. There can be history of diarrhea, weight loss in enteropathic arthritis. So these are some of the clinical clues for us, systemic, which suggest of uveitis. But very underrated again is basic investigations, which can sometimes show neutropenia, thrombocytopenia, leukopenias, thrombocytosis, which if you are able to identify, then you can think of, say, patient has features of retinal vasculitis and has leukopenia, thrombocytopenia, then I'm very, very interested to rule out lupus. X-rays again, they are very, sometimes maybe very gross findings, like this bamboo spine. Chest X-ray can show some hilar adenopathy, or this may also be a bilateral pulmonary artery aneurysm in Behçet. So these are just some glimpses, just to put across that simple investigations like a CBC, urine routine, or an X-ray can help us in diagnosis. So how as we rheumatologists approach this is again history and clinical examination, looking at the pattern of arthritis, looking at extra-articular manifestations, looking beyond the joints, looking at like the skin, eyes, GIT, cardiopulmonary manifestations, with family histories, comorbidities, drug histories, keeping in mind about mimics, and that usually gives us the diagnosis in majority of patients. Many diseases still may start with the eye, which is we may not have clinical symptoms elsewhere, where it is very difficult. We may need the help of investigations, but majority of patients otherwise we can make a diagnosis based on these features. So some take home, CTD present with varied manifestations, a thorough history and physical examination is very, very important. And looking at the arthritis, the pattern of arthritis and extra-articular features are very crucial clues for diagnosis. And then only we use investigation to supplement and not substitute our judgment. Thank you.
That's an excellent presentation and eye-opener for us. So the very important message for us ophthalmologists is do not refer to rheumatologist just because the patient has got uveitis. You take the thorough history, do a basic systemic examination before you refer to them. So now after examination and thorough history, we should talk about treatment. So shall we start the patient on steroids just like that? When to start steroid? We have a speaker, Dr. Vinay Kumar, who will be talking on before you start steroids in uveitis, what all things we should be careful about.
At the outset, I would like to thank Dr. Ankush, Dr. Padma Malini, and BOS for the opportunity. So, when Dr. Ankush gave this topic to me, so I was thinking what to present. So, before you start steroids in uveitis, the only one answer I got is you have to think before starting steroids, because it would affect our treatment, and if at all we are referring the patient to our uveitis specialist, then they will be clueless if we have started the steroid, both in terms of the classification, both in term I would go through how it alters the management, how it alters the diagnosis of the patient. So when we start steroids, our major aim is just to decrease the inflammation, but it does have other ramifications, so that those things should be kept in mind before starting steroids. So because of all those metabolic effects and other effects on other systems, it has various systemic side effects, so that has to be kept in mind. And when we say steroids can be given in various forms, topical administration, intravitreal injections, and periocular steroids and systemic steroids. And mode of giving systemic steroids depends on the severity of the disease and whether it is site threatening or not. Especially we should be very careful when we are giving depot preparation like periocular steroids and intravitreal steroids because that would reactivate the infection. So before starting steroids, if possible, what we should think is if it is a local problem, better and a milder problem, then it is better to start local steroids. And always use the smallest dose which is needed to control the disease. And the tapering should be gradual, and you should monitor the BP, and especially in elder individual, we have to monitor the bone density, especially when we are planning to keep the patient on long-term steroids. As sir highlighted, history taking is very important. For example, if a patient has history of glaucoma, or already patient is known to have steroid responder, then we'll have to take glaucoma consultation before starting steroids. And whether the patient had any TB or any recent admission, that gives us a clue. Like Dr. Padma Malini was mentioning patient with COVID. There are various studies which have shown endogenous endophthalmitis post-COVID, or any recent history of fever would we would lean towards post-fever retinitis. So that kind of history is very important. And history of gastritis especially. So there are many reports where patient had bled internally because of bleeding, ulcers, patient with GARD. So we have to take a thorough history of gastrointestinal symptoms, and history whether the patient is a pregnant lady or she is lactating, that should also be taken. And we should also ask for history of diabetes and hypertension. And in our clinic, most of the times patients are very apprehensive when we start steroids, especially 1 or 2 weeks post starting, they will have acne over the forehead, back. So many times patients do discontinue because of weight gain. So if we have thoroughly counseled the patient before starting the steroids, then the compliance improves. For example, this was one of our patients where patient had Cushingoid features. Especially for females, this is very cosmetically disturbing. And as I said, in elderly individual, we'll have to be aware of avascular necrosis of the femur. So this lady had avascular necrosis of the femur also in the left side. And before starting steroid, we should, if at all we are intending to investigate, before starting the steroids is the right time to investigate, because in CBC it increases the WBC, and any infection and can also increase the WBC. But steroid induced increase in WBC, usually it will affect the neutrophilic cells more, and it has lymphocytic lymphocyte count also can decrease, and overall any antibody level can come down because of the anti-inflammatory effect. And ESR and CRP will be falsely low if the patient has already been started on steroid. That has to be kept in mind. And even ANA titers can be low if the patient is already on steroids. So it is better to investigate before starting systemic steroids. For example, I would like to highlight the importance of not giving depot preparation before ruling out infection. For example, this patient was a case of intermediate uveitis with a peripheral CRA scar diagnosed elsewhere, and they had given periocular steroids. 2 weeks post giving steroids, there was reactivation at the edge of the toxoscar. So they didn't consider toxoplasmosis as a diagnosis in this patient, which led to reactivation at the edge of the scar. So then later we started the patient on Bactrim and oral clindamycin, and the patient resolved and the vision improved. And this was one another case where elsewhere it was diagnosed as intermediate uveitis, and they had given triamcinolone acetonide in the vitreous cavity. And actually, unfortunately, we lost this eye despite doing, giving a lot of intravitreal antibiotics and antifungal. We had to eviscerate this patient, and biopsy showed Aspergillus flavus. Actually, it was a fungal uveitis which got aggravated because of intravitreal steroids. This was one another case where it was diagnosed as acute anterior uveitis, fibrinous anterior uveitis elsewhere, and started on steroids. This is just 2 days post starting steroids. This was a case of endogenous endophthalmitis, and actually, just a B scan and a history of urinary tract infection would have saved the eye in this patient. So we did PCR, it grew, it was positive for E. coli, and even the culture was positive for, culture grew E. coli. So in such scenarios, it is very important to consider infection. Not all anterior uveitis, acute anterior uveitis is endogenous endophthalmitis. And this was one case which I have published where patient presented with multiple yellow subretinal lesions, wherein it showed elevated choroidal lesion with subretinal fluid there. Actually, I was thinking of doing imaging just before. He was a 33-year-old male. I wouldn't suspect hypertension in this patient, but the message in this case was just before doing fluorescein angiogram, we just did, we checked the BP. BP was 220 by 140. So I was thinking of investigating him systemically. I just said nothing doing. We just control the hypertension and it resolved. This is the image 3 days post control of blood pressure. So not all cases with subretinal yellow deposits are choroiditis. So we'll have to think in terms of other systemic association. Actually, I could not put those images, but this patient showed segmental arterial narrowing, which are very classic of hypertension in young. And one more thing is we have to differentiate whether it is VKH or multifocal CSR. This is extremely important because VKH you treat with steroid. In multifocal CSR you avoid steroid. So there are few clinical signs. I won't go into details of those clinical signs, but you have to look in mainly the recent concept is bacillary layer detachment, which is more commonly seen in VKH. Of course, it is seen in CSR. There are no signs which will absolutely differentiate these two, but depending on like whether like PED is more common in CSR, disc hyperemia is more common in VKH, and when you do a fluorescein angiogram, disc leakage is more seen in VKH. And otherwise, like if most like 50%, 1 in 2 patients with early VKH may not have any vitreous haze, so that could also be misleading. So we have to be careful before starting steroids in such patients. And when it comes to postoperative inflammation, we have to differentiate whether it is TAS or endophthalmitis based on the, at least we have to do, before presuming that it is TAS. Of course, there are multiple differentiating factors between these two, but it is better to rule out infection before starting the patient only on steroids. Of course, endophthalmitis also we do give oral steroids, and it is controversial, but standalone steroids in such cases would be problematic. And as it was highlighted in vitreoretinal lymphomas, when the patient has been having recurrent episodes of inflammation which responds to steroids, again it recurs. So in such patients, if you want to rule out vitreoretinal lymphomas, you have to do biopsy only after stopping steroids for at least 2 weeks, 1 to 2 weeks. And in case of acute anterior uveitis, if you are thinking of doing a PCR, it is better to do before initiating the therapy, because there are studies which have shown that the probability of finding viral DNA in anterior chamber is better when it is done before starting steroids. So that has to be kept in mind. And as highlighted, in cases of in cases where there is first of all, we have to dilate all cases as it has been highlighted, and if there are, and especially shallow anterior chamber, sometimes we hesitate to see if there is intense inflammation. Sometimes peripheral toxo can also present like that. So that also can be like if you start the patient on steroids alone, then it will flare up. So there are, for example, in this case report, this patient was resistant to even systemic immunotherapy. Their herpetic necrotizing retinitis happened after fluoromethalone implant. And the other thing which we should be aware of is rifampicin accelerates the clearance of steroids. So before starting steroids, we should, if at all we are treating a patient with serpeginoid choroiditis or something, if it is not responding to the dose at which we expect it to resolve, please think that because rifampicin can interfere with the clearance and bioavailability of steroids, stepping up can help. So in breastfeeding, like till I prepared for this presentation, I was under the impression that it should not be given, but actually in breast hardly any prednisolone goes into the blood. It is very, very low. There are few consensus that earlier it was told that at least 4 hours gap should be there between the breastfeeding and this thing, but it is not supported by the literature. Even in pregnancy, cleft lip, cleft palate was this thing, and gestational diabetes was also told to be higher in such patients, but it is not supported by the literature. And especially in children, growth retardation is one thing which you should be aware of, and there are few studies which says that growth hormone can reverse these changes. But before initiating, we have to consult the pediatrician or the pediatric rheumatologist to opine on that. And in HIV patient, we should be very careful before starting steroids because it can lead to life-threatening complications. Thank you.
So now once you have ruled out all the infections, you have made a diagnosis of non-infectious uveitis, and it's a chronic or recurrent uveitis. How long you can treat the patient with repeated episodes of uveitis with prolonged steroid medications? At some point of time, you have to start on some steroid-sparing agents. So let's see how and when the uveitis specialists consider immunosuppressive therapy in treatment of uveitis.
Good afternoon. Thank you, BOS, for this opportunity. Okay. So we'll move on to our next talk of when do we consider immunomodulators in uveitis. First of all, we have to be sure that we have established a diagnosis of non-infectious uveitis before we consider the treatment. And though it's a fact that steroids are the most potent anti-inflammatory and immunosuppressive agents and most rapidly acting, and they are the primary line of treatment, but because of a plethora of side effects being systemic as well as regional, we want some alternate medications. Why? Because uveitis, we know, is a chronic condition which can have a prolonged course with remissions and relapses, can cause ocular complications because of the uncontrolled inflammation, and can be sight-threatening. So the MUST trial was a multi-center uveitis steroid treatment trial, which was a randomized controlled trial of including 255 patients of non-infectious uveitis who were randomized to receive either intravitreal steroid implant versus aggressive systemic immunosuppressive therapy with systemic steroids, and they found that similar effectiveness of both the treatments in control of inflammation was seen. Also, long-term treatment with immunomodulator was found to be safe and well tolerated as per the study. And a 7-year extension of this study with a cohort of 180 patients who received systemic immunomodulator therapy had much better visual outcomes when compared to that of the local treatment with the Retisert. So this established the safety of the immunomodulators and their efficacy. So when do we consider immunomodulatory therapy? Is the Fundamentals of Care of Uveitis was published in 2018. It was a evidence-based recommendations from a group of experts in the field of Uvea and rheumatology, and they gave their recommendations in the form of therapeutic indications whenever there's a failure to respond to steroids, be it regional or systemic, or whenever there's a relapse of uveitis on tapering the steroids to the safe dose. The safe dose is considered as less than 10 milligrams per kg per day. 10 milligrams per day. So, or for longer than 3 months, if the patient requires this dose, then it's better to consider shifting to immunomodulators. Whenever there's intolerance to steroids because of the systemic metabolic disorders, hypertension, blood control, diabetes, or when there's a need for steroid sparing in patients who have active infections or have gastric ulcers, osteoporosis, etc. So, the ocular and anatomic indications for starting immunomodulators are whenever there's an acute site sight-threatening inflammatory disease, when there's a persistence of inflammation, whenever the disease is more posterior involving the vital structures like the disc and the macula, or whenever there's a binocular sight-threatening disease. And depending on the severity of the inflammation, whenever the visual acuity was less than 20 by 100, or the worsening of vitreous haze of more than 2 grades, relapses in macular edema or cystoid macular edema, or whenever the patient starts developing any kind of uveitic complications like the presence of glaucoma, cataract, posterior synechiae, band-shaped keratopathies, macular edema, ocular hypotony, or rubeosus iris, then we should think of putting them on immunomodulator therapy. So also whenever there's associated systemic conditions like VKH is a systemic disease, there's ocular haradas. Along with that, there's also neurological and integumentary findings, or in case of Behçet's disease or other autoimmune diseases are present, then it's always better to consider systemic therapy than just local therapy, and especially immunomodulators. Or when there's an extensive tissue destroying like a necrotizing scleritis associated with GPA or rheumatoid arthritis, in such cases also it's better to consider immunomodulators. Whenever there's a chronic disease which has a prolonged course with remissions and relapses, like a serpiginoid choroiditis, which we can see here, the macular active lesions, and the FA picture also showing the corresponding hypo with hyper borders, hyperfluorescent borders, or when there's a vasculitis, like with the extensive neovascularization already starting at the time of presentation, and the typical vasculitic leak, small capillary leaks, which are seen on the FFA. These are the things when we should consider, because they are all prolonged diseases and they are sight-threatening. Pediatric uveitis is most desirable to have steroid sparing in pediatric cases, especially with JIA, because we already saw the previous presentation. So when we have this kind of a picture in a child with cystoid macular edema, posterior synechiae, cataract, BSKs, they all go in for these because they are most of the times asymptomatic. So then we have to make a diagnosis and start them more earlier rather than later on immunomodulator therapy. So the SIGHT study was again one of the landmark studies. This is systemic immunomodulatory therapy for eye disease. Was a retrospective study of almost 8,000 patients over a period of 25 years of non-infectious ocular inflammatory disease. And they've established the fact that there was no significant increase in overall and cancer-related mortality among patients who received immunomodulator therapy compared to the general population. But they also said that immunomodulators are not fail-proof. As we see in the table, the immunomodulators will produce a sustained control of inflammation with a minimum dose of steroid, that is around up to 5 mg of steroid was allowed, and only up to 60 to 75% of the population, and not all 100%. So systemic immunomodulators are not fail-proof. So how long do we continue with immunomodulators? We have to use them up till a complete remission of inflammation has been achieved off the steroids for at least a period of 1 to 2 years. And then we can consider slow tapering of the medications. Pre-treatment tests, yes, is very important because we are dealing with drugs which are affecting the actively dividing cells in the body. So all the vital organ functions like liver function, kidney functions, a complete blood count, screening for all infectious diseases, ruling out pregnancy, as well as cardiovascular system status has to be evaluated before we start on these medications. But certain the immunomodulators we know are very effective, they are quite safe, it can be used for long periods, but they are not very cost effective. When compared to steroids, they are much more expensive and they require a very careful, regular monitoring of the patient. We cannot have a patient lost to follow up taking these medications. So they can be classified as the conventional immunomodulators and the biologics. So the conventional immunomodulators are categorized in the 3 groups of antimetabolites, which include azathioprine, methotrexate, and mycophenolate. These are the ones which are most widely used in the uveitic patients and most widely studied also in many of the uveitis studies. Then coming to alkylating agents, they cyclophosphamide and chlorambucil, they are usually much more toxic but very effective immunosuppressive agents. So they are used for acute conditions like a necrotizing scleritis and some other pemphigoid kind of lesions. And then there are T cell inhibitors or calcineurin inhibitors, which include cyclosporin and tacrolimus and sirolimus. So I'll not talk about each drug because of the time constraint. And then there are certain biological agents. Now these are the relatively recent medications which have been added. So they are therapeutic proteins which block the activity of biologically active molecules. The examples, they have been further classified as the tumor necrosis factor alpha inhibitors, which include infliximab and adalimumab, the interleukin 6 inhibitors like tocilizumab, B-cell inhibitors like rituximab, and Janus kinase inhibitors of tofacitinib. So the advantage is because they are highly specific, they are specifically targeted therapy. They have much lesser adverse events, but there's a disadvantage with these agents also, because they can activate latent infections like tuberculosis, which we already saw in the previous presentation, and live vaccines are contraindicated during the use of these agents. They can aggravate also demyelination, ANA positivity, cardiovascular risk factors are seen with these biological agents. So there are certain studies which have also, like the visual 1, 2 and 3, which also determined the safety and efficacy of the use of adalimumab for on prolonged treatment. It was found to be very efficacious for all the cases of non-infectious uveitis, which resulted in FDA approval of adalimumab to be used for non-infectious uveitic entities. And the visual 2 established that adalimumab can be also used as a maintenance therapy as a safe alternative to steroid for preventing flare-up of non-infectious inactive uveitic during the inactive stages also as a maintenance. And visual 3 said that long-term safety of adalimumab in non-infectious uveitis, the adverse event profile was within the acceptable risk level. So they do have their own risk, but they have found that there was not much more than the general population, and hence, so they are found to be effective. So this, thank you.
For enlightening us with the use of immunosuppressive agents and biologics in uveitis with the landmark studies. So most of the times we do immunosuppressives in collaboration with rheumatologists. Now I would like to hear from Dr. Vikram Raj Jain from his point of view for the guidelines for the use of immunosuppressives in uveitis. Over to you.
Thank you, ma'am. I think what we usually, our approach obviously is use of medication. We start off with most commonly, most indications, I think methotrexate or would be something which we would want to use. But again, specific indications like Bechet, or where we have to specifically use azathioprine or cyclosporin, or depending on the severity, the urgency, if you want acutely life-threatening, you want cyclophosphamide, retinal vasculitis. So depending on the anatomical location, depending on the disease, and depending on the urgency, I think the choices will be made. And again, whether it is responding to one refractory or not, again, we would switch over to biologicals. So we have something like a treat to target, like we do in arthritis. One doesn't work, next one doesn't work, next. So, or a combination of medication depending on the patient's affordability and the other comorbidities and what patient tolerates. So I think a lot of factors go into what deciding what we end up choosing. We would want to choose something, but sometimes a lot of factors don't allow us to use those medications. But I think these are some of the pointers which I take in try to use these biologic medications. Thank you.
Yeah, we like to share. We had a patient, one eye use of following biologics. He developed occlusive retinal vasculitis secondary to tuberculosis. He was a steroid responder. So we end up putting the patient on cyclizumab, and patient responded well, and we published it. Thank you, sir, for taking care of the patient. Yeah, we have seen uveitis, the management with steroids, then immunosuppressive therapy. Then if they don't respond or refractive cases, we go for the surgical management, or now the trend is changing, even for making diagnosis, even in the presence of active uveitis, we end up doing surgical interventions in uveitis. I invite Dr. Naveen Kumar Nayak to speak on surgical interventions in uveitis. Over to you, Dr. Naveen.
Good afternoon. First of all, thanks to Padma ma'am and Ankush and boss for considering me for this. I'll be talking to you about when do we actually consider vitreoretinal intervention in a case of uveitis, which is largely medically managed. Astoundingly, 15% of posterior uveitis goes without an etiological diagnosis. And it was surprising to see that it was way early as 1981 that vitreal biopsy was part of the uveitic armamentarium. And ever since its inception as a diagnostic modality, in non-infectious, it is given yield in 64 as high as 64.3%, and in infectious as high as 77.1%. So why this inclination towards vitreoretinal intervention now in the management of uveitis? A lot of it goes to the bettering in the instrumentation. That is, with the advent of the instrument vitrectomy system, there is a shorter surgical time, the faster recovery, and also the tissue handling is not compromised much. Why the tissue handling? Because most of our uveitis patient can sometimes end up with glaucoma. In case you want to do a trabeculectomy or a valve procedure, later you always have a well-preserved conjunctiva for future. And also with the good close vitrectomy system, you have a high chance of getting a good volume of vitreous, which can be subjected to various investigative modalities. And also because of the better instrumentation with the newer cutters with the high cutting rates, you have a decreased rate of complication as opposed to as late as endophthalmitis vitrectomy study, where most of it was done with 20 gauge vitrectomies. The disadvantages were more as opposed to the advantages. Hence, you would actually intervene when the vision was quite poor as opposed to when the vision was better. Coming to the diagnostic utility of MIVS, as I said, when the inflammation is confined largely to the posterior segment, the AC tap taken and subjected to any of the investigative modalities would not give you a good result. Hence, a vitreous biopsy is what you really want then. Coming to the therapeutic vitrectomy, one of the biggest advantages is it counters the inflammation locally. It reduces the cytokine or other inflammatory mediators locally, as a result of which there's a faster resolution. Literature also supports that once you've curtailed it, the long-term recurrence of the inflammation per se comes down. And apart from that, whenever you have an obvious vision-threatening complication, like either a vitreous hemorrhage post-vasculitis, or it's a regmatogenous RD post-ARN, or an epiretinal membrane, or a non-responding CME, that's when the therapeutic vitrectomy really helps. Coming to the sample collection, this is quite a challenge, though it looks simple. It could be either the vitreous or the chororetinal biopsy. We always choose to take 1 to 1.5 ml of undiluted sample. This gives our best results when subjected to any of the investigations. But the only thing is we need to externally keep the pressure, keep an indentation on the globe so that the volume doesn't collapse and there's no bleed internally. Some of them prefer to do it with the support of PFCL. Some of them do it under air too. But personally, I don't prefer under air, because when we are doing it in a phakic patient, if further on I'm going to do a complete vitrectomy, that would be quite a challenge. Coming to chororetinal biopsy, as all of you have mentioned, whenever we see the response is not what we expect, there's a masquerade or there's a suspected lymphoma, is when we do a chororetinal biopsy. Even in this, a thorough PVD induction and a complete vitrectomy, before you start, you take the chororetinal biopsy is very important, and it's very important to laser it adequately once you've done it. And using a tamponading agent post that is an option based on how the scenario there is. I would like to share a few of my case examples that we've had, which have actually, where we've seen that the vitreous biopsy or a therapeutic vitrectomy has helped. This was a 32-year-old female who presented to us with a bilateral non-granulomatous panuveitis with CME. She had a previous history of Legionella infection and she was in the ICU for 2 months. Because of a past history of infection and long time spent in the ICU, we were inclined towards an infective etiology. We did a right eye AC tap and sent it for PCR, which came positive for streptococcus. The first treatment that we did was an intravitreal vancomycin, ceftazidime and a dexamethasone. To begin with, initially her CME responded quite well, but later on started to show recurrence. We did a similar AC tap in the left eye, but the PCR was initially negative. And after a couple of weeks when we did, we got an isolate of propionobacter. This startled us more. We were really not understanding as to what we are dealing it and what organism to. target. In this, we gave an intravitreal dexamethasone, and it showed a good response. One surprising thing that we saw in this patient was, even though it was just the dexamethasone during the initial treatment that we gave, the effect lasted for more than 3 weeks. That was something surprising. While the right eye, as I mentioned, started to show recurrence in the CME, and the vitreous haze was persisting, and the patient was quite symptomatic. And we were also not really comfortable as to what we are dealing with. At the same time, it was during this when she had a sudden onset of breathlessness, and her chest physician found on her X-ray or the CT multiple locular lesions in the lung. And again, here we were again startled, and he was suspecting fungal. So we were again startled as to what we are dealing with, because the patient was already on long-term steroids, immunosuppressive antibiotics, and she, at this point, after 2 months of, we'd kept her systemic steroid to a low dose as 20 mg, but it was soon seen that she started appreciating the side effects of the steroid per se. So this is when we explained to her as to the next challenging thing that we would do in her, having given to her all the pros and cons. We took a vitreous biopsy and also did almost a thorough vitrectomy in her. And the PCR, luckily, that we subjected to had no isolate of any organism. So in consensus, we went ahead and gave an intravitreal dexamethasone too. And we see that the right eye CME has been kind of responding very well ever since. And even the patient is symptomatically much better. So in this, we know that the vitreous biopsy helped us rule out an infective etiology and made our management a little more targeted. Coming to our next patient, this was a 35-year-old gentleman. He presented to us with a left eye non-granulomatous panuveitis with a retinitis temporally. And he came to us for a second opinion. He was previously treated by a rheumatologist wherein he was positive for HLA-B27. They attributed the issue to the B27 concern, and they had started him on methotrexate already. But this was his fundus picture to present with the left eye. The right eye was uninvolved. The left eye showed a vitreous haze and a temporal retinitis patch. We subjected him to an AC tap, and it came out positive for herpes zoster. We immediately started him on oral valcyclovir and oral steroids. But again, after close to a month's time, the patient still had a lot of vitreous reaction persisting, and the patient, being very symptomatic, is a software engineer, and he's been very symptomatic, disturbed by the floaters that he constantly sees. And initially, also to begin with, the retinitis showed a good resolution, but it persisted to stay there rather than recover, though we had a diagnosis at hand with the PCR reports. So this is when in him we did a media clearing vitrectomy and an intravitreal. In this again, the PCR of the vitreous biopsy again came positive for herpes. This was a little surprising because most of the time the harvest of the zoster coming in after the steroid is unlikely, but the PCR did help. And we gave an intravitreal dexamethasone before we closed. This is how the left eye looks now. The media much clearer, the patient very happy, and the retinitis has healed really well. Here the vitrectomy has really helped in a faster resolution of the disease per se. Coming to our third patient, this is a 50-year-old male with SLE and vasculitis in the left eye. And he had a severe vasculitis and a dense ERM. He was post PRP and he had 2 doses of Ozurdex previously for his recalcitrant CME. During the course, as I mentioned, he had an epiretinal membrane and his visual acuity had dropped down to close to 2 meters. We went ahead and did a pars plana vitrectomy with epiretinal membrane peeling, and before we closed the gaze, gave him a dose of intravitreal triamcinolone acetonide. This is to show the OCT features pre-op and post-op. You'll see seeing that the retinal architecture is trying to get back to normalcy. And his visual acuity improved to 636. So here we see that vitrectomy really helped in a better functional and an anatomical outcome. And I can't emphasize the fact that how vitrectomy or a vitreous biopsy can be important in endophthalmitis. Very recently we had a patient of post-op endophthalmitis. Unfortunately, the surgeon thought it is a TAS, and he started her on steroids. And when they came, they referred to us when the hypopyon was fully blown and the vision had dropped to hand movements. In this patient, even though there was a little corneal edema, we went ahead, did a vitreous biopsy and a vitrectomy, and luckily enough, we could induce PVD. But as a caution, I didn't go to actually remove the entire skirt of the vitreous periphery, because you can actually induce breaks rather than do good to the patient. And we gave her intravitreal Vanco, Cefta and Dexa, and the isolate came as Pseudomonas. Luckily, at 2 weeks post the vitrectomy, the patient is doing well. We've just given her intravitreal Cefta and Dexa in the last 2 weeks. Two every weekly we're giving her one. The glow has gotten better, and the patient vision-wise is also much better. So to summarize, MIVS or vitrectomy per se, as we know, is not only helps in combating the inflammation locally, also reduces the recurrence of the inflammation or the issue per se. And also, once the disease is targeted locally, the need of systemic immunosuppression and corticosteroids are reduced, thereby reducing the need or the adverse effects of these drugs per se. As I mentioned, the diagnosis is much, much better and helps us have a direction in our treatment. And definitely, yes, early intervention, whenever you feel the patient can do well, helps in functional outcome too. So an open mind is what makes a closed system of MIBS a great option in uveitis management. Thank you. Thank you.
Challenging cases. Thank you so much. Next, we'll move on to the last presentation, challenging cases and case scenarios by Dr. Namita Dave. Over to Dr. Namita.
Good afternoon, everyone. Thank you, POS, for giving me this opportunity. I shall be presenting some of the challenging cases, and here I will stick to some of the pediatric uveitis cases, which are more of a challenge in our clinical practice. When the disease has an earlier onset, stakes are high. And challenges in pediatric uveitis, patient starts right at the first visit to the OPD with examination difficulties, anxious parents, and a delays in diagnosis. Management is more difficult with them because they are chronic, recurrent, and are often resistant to treatment. Moreover, risks of amblyopia and a lifelong burden of visual loss affects the life of the child. Now, this first case here is a 7-year-old male who presented with photophobia and redness for 2 days. He was admitted in the hospital for fever, upper respiratory tract infection, and arthralgia, and was on treatment with antibiotics for the past 2 weeks. And the examination was very difficult for this child and was done under sedation with the help of the handheld slit lamp. Anterior segment showed inflammation, anterior uveitis with the fibrinous membrane in the pupillary area. There was posterior synechia, and the posterior segment could not be visualized at that point of time. B scan showed the presence of vitritis. Hence, here we had a bilateral anterior uveitis with spillover vitritis. Topical steroids and cycloplegics were started, and investigations advised, which showed raised ESR and CRP levels. Other imaging investigations were normal. Now, the following week, the anterior segment was much clearer, helping us to visualize the posterior segment, which showed optic disc edema, hyperemia, and retinal vasculitis. Now, we have a case of panuveitis, and under the supervision of the pediatric rheumatologist who was treating the child at that point of time, or IVMP 250 milligrams were given for 2 days, and oral steroids were continued. Now, as he was was under the treatment of the rheumatologist for undifferentiated arthritis, the parents gave a history of persistent diarrhea and abdominal pain, and a pediatric gastroenterologist's opinion was sought. Colonoscopy was done, and segmental biopsy taken and sent for histopathological examination, which showed the presence of multiple granulomas, crypt abscesses, and they ruled out your infective etiologies with special stains of rule out fungal and tuberculosis. So now we have a patient of bilateral panuveitis associated with an inflammatory bowel disease. Patient was started on adalimumab 20 milligrams for every fortnightly along with tapering steroids. Meanwhile, the anterior segment showed resolutions. However, like children tend to develop posterior subcapsular cataract very easily. So here the child has already developed posterior subcapsular cataract and there is presence of bilateral cystoid macular edema. The treatment was then continued with azathioprine and methotrexate along with pentosa for a better control, and systemic conditions improved, so did the ocular conditions. OCT showed the resolution of the cystoid macular edema. However, the posterior subcapsular cataract was now present in both the eyes, and after strict control of inflammation and under the perioperative in steroid therapy, cataract surgery was done, and the child is still being followed up with 6/6 vision in both the eyes at this point of time. The second, there is another interesting case of a 14-year-old girl who presented with blurring of vision in the left eye since 1 week. Anterior segment evaluation showed presence of anterior segment inflammation with diffuse keratic precipitates, cells of 3 plus, and anterior segment antravitreous showed cells as well. There was no systemic complaints at that point of time. Posterior segment was very hazy and a B scan suggested presence of vitritis. And this is the case of here this is an acute episode, first episode of anti-uveitis in a young female with no systemic association at this point of time. Topical steroids were started along with cycloplegic. 2 days later the vision showed improvement to 6/24, but no other changes were noted at that point. Topical steroids were continued along with the cycloplegics, and over 2 months the vision acuity improved to 6/6, but there was persistent vitritis, and fundoscopy showed peripheral sheathing of vessels. Fundus fluorescein angiography was done, which showed leakage from capillaries and peripheral vessels with areas of capillary non-perfusion and staining of the disc in both the eyes. So bilateral panuveitis with vasculitis was made, and the child was physically evaluated. Now the child was physically short-statured for her age. There was presence of leukoplakic lesions in the mouth, which could also have been candidiasis. There was nail dystrophic changes, or they could be fungal. Here the systemic workup was done, which showed lymphopenia, and urine had pus cells and leukocytes. Immunological workup showed an inverted CD4 to CD8 ratios with normal immunoglobulins. The torch panel was done where IgM CMV was positive. High suspicion of secondary immunodeficiency was maintained, and it was retested for HIV by the dermatologist again a week later, and it was still non-reactive. So here we are looking at immunodeficiency in the absence of HIV. Comes to mind a primary immunodeficiency or a CD4 lymphocytopenia. Lymphopenia, T-cell deficiency, oral leukoplakia, short stature, splitting of nails pointed towards primary immunodeficiency, but however the immunoglobulins were normal. Then we have the idiopathic CD4 lymphocytopenia supported by low CD4 cell counts without evidence of HIV infection, and UTI showing pus cells and or possible oral candidiasis. Evaluation was further was done where the heterozygous missense variation in the exon 18 of the HTEL1 gene was noted, which along with the physical features of short stature, oral leukoplakia and nail dystrophy pointed towards disc keratosis congenita. The child was started on oral visolone along with antibiotics and antifungals. Now literature search supported a diagnosis where they have noted number of vasculopathies in patients with disc keratosis congenita. But this was just the beginning. We thought we had reached somewhere. 4 months later, the child comes back with occasional cells in the anterior segment with minimal vitritis and sheathing of vessels still present. The fundus fluorescein angiography here again continued to show persistent leakage from the capillaries and peripheral blood vessels with areas of capillary non-perfusion and staining of the discs. It's been now almost 1 year after the initial presentation, but picture has not changed much. Now comes a twist in the tail. The child is been identified to have choledochal cyst and has to undergo surgery, for which the routine preoperative investigations have been done. Here what they find is that she tests positive for HIV on Western blot, and they need to start on antiretroviral therapy. So now we had the patient in the first presentation was HIV non-reactive, T-cell deficiency with genetic testing positive. Week later, HIV was repeated on suspicion, which is again negative, non-reactive, but 1 year later it is now positive. So is this keratosis here just a coincidence, or are we looking at a coexistence of primary immunodeficiency along with HIV? What else should be the method of choice of HIV in such a case? However, a high index of suspicion has always to be maintained at all times, so we just need to keep retesting whenever there is a doubt. Now this is another interesting case of a 12-year-old male child who came to us with worsening of vision. Now this child who had been was under treatment for idiopathic anterior uveitis on topical steroids. The vision in the affected eye was hand movements. Anterior segment showed the occasional cells. As we said, he was on topical steroids. Dilated examination was, I do not know whether was done or not, but the vitreous had almost a 3 to 4 plus haze. And dilated examination, which has to be done, will clinch the diagnosis. Here we have multiple patches of retinitis, and see the OCT running through the lesion shows retinal necrosis, intense vitritis, and maintenance of the choroidal architectures, pointing in favor of retinitis, which is probably of viral etiology. Certain investigations were there with the patients which were normal. On clinical suspicion of ARN, the tablet acyclovir was started, and along with topical steroids. AC-TAP was done at that point, which was positive for HSV2. The tablet Visolone was added to the treatment. However, there's been a delay in the treatment, and the B scan now is showing a minimal retinal detachment. The child was taken up for vitrectomy, fluid exchange, and at this point vitreous sample also was taken, which was again positive for HSV2. The vision improved to 6:30 at this point. However, just 4 days later, the child returns back to the clinic with a bullous retinal detachment. The child has to be taken again for surgery, and at this point silicone oil tamponade is done along with an endolaser. Proliferative vitreoretinopathy changes were there, and epiretinal membrane peeling was done under silicone oil as well. Later, once the scarring had been reached and there was no more active inflammation, the cataract, again as he said, children develop cataract very soon. Here the child required cataract surgery for rehabilitation. The eye has been quite since and maintained. So here we see a posterior segment evaluation could have probably picked up the retinitis, and the child could have been treated earlier, avoiding so many delayed, so many interventions, so many surgeries. Now early diagnosis we know is essential for proper treatment, but in children the complete examination may be more challenging compared to the adults. Early aggressive therapy improves ocular outcomes, and complications of cataract can be more problematic when it comes to children. Elimination of all inflammation is a cornerstone of therapy. However, in children, long-term low dose of corticosteroids may not be possible, unlike adults. Thank you.
Thank you, Dr. Namita, for presenting the challenging cases in pediatric age group. Yes, coming to the second case where she raised the question regarding the HIV is negative and turning to positive after 1 year. So HIV can be negative when we test in the incubation period or in the latter stage of the disease, in the end stage disease. So that way, suppose when you have high index of suspicion, when the HIV 1 and 2 is negative, preferable to check for the antigen load, viral load, that can help us to clinch the diagnosis when we have high index of suspicion. So since, thank you. We thank BOS, Dr. Pallavi Joshi for giving us an opportunity to hold a Uvea session. I thank Dr. Ankush for coordinating the session. Thank you, Dr. Anjana, to giving the nice keynote talk coming all the way from Madurai. Thank you. And also we thank Dr. Vikram Raj Jain, rheumatologist, for joining us, highlighting the use of systemic immunosuppressive therapy. We thank all the BOS speakers. Thank you, one and all. Thank you. Hope enjoyed the session. We hand over to the next session. We got the session 15 minutes late, so we are handing it over to you also. Maybe 5 minutes. Thank you.